Hello, welcome to the Health System Division's presentation on Oregon Health Plan service delivery and the CCO enrollment processes. We're going to be covering several things today. You see on the slide there, one, we're going to talk about the service delivery options. We're going to talk about enrollment exemptions and what those are. We're going to talk about the change process and the timing for that around how enrollment and disenrollment works. And we're going to have some contacts and resources for you to research after today's presentation. So our first topic is about the Oregon Health Plan service delivery model. The next several slides are going to be some definitions that we're going to use throughout today's presentation. So I want to go through these one at a time. Some of these you probably have heard of before, but for those that are new, I want to make sure that we all understand things like the Social Security Act of August 14th, 1935. The original Social Security Administration Act, or Social Security Act, consisted of 11 titles. There's now 21. The two that are important for our presentation are Title 19, which grants states the medical assistance programs, and Title 21, which is the State Children's Health Insurance Program. Our next definition, again, around the Oregon Health Plan, OHP, which again is at Title 19, the Medicaid program, which helps cover medical expenses for people with low income, and the Title 21, the Children's Health Insurance Program. So these next two definitions are very important because they often get used interchangeably, and so I want to make clear why they're different things. So eligibility is the status of whether a person has the Oregon Health Plan benefits. That is different from enrollment. Enrollment is when an eligible OHP member's benefits are administered by a coordinated care organization. So you can be eligible for the Oregon Health Plan but not enrolled into a CCO. I think a lot of times we use those words interchangeably, and they can confuse the status of what an OHP eligible member has. All right, service delivery. OHP members receive services through one of the following service delivery options. We already kind of talked about this. The first is coordinated care. So the state of Oregon Health Authority contracts with health plans. We have 16 of them throughout the state of Oregon to handle the prior authorization, billing, basically the services that those members receive, and that's about 90% of our population right now. The other form is fee for service, which essentially is that there is not a coordinated care organization, and those members' benefits are paid directly by the state, including the prior authorization process and billing. So one important distinction to make is that coordinated care actually is made up of 4 different things. Depending on the service area, depending on that member's needs, depending on if they have some exemptions, which we'll talk a little bit about later, they may have one of the 4 types of coordinated care organizations. The first is CCOA, which is the full integration. The physical, mental, and dental benefits are all covered by the CCO. The second is physical and mental health, the CCOB. That means that the dental coverage, oral health coverage, is not covered by that CCO. The third is the CCOE, which is only mental health coverage, meaning, again, the physical health and the dental health are covered on a fee-for-service basis. And the last is a CCOG, which is the mental and dental health. I know that is a confusing concept. The goal for the Oregon Health Authority, for the Oregon Health Plan, is to move as many people into the fully integrated model, the CCOA, as possible. But depending on exemptions, depending on what type of coverage that member has, there may be cases where they're in one of the other 3 types. So at this point, I'll turn it over to Cheryl Wood and let her introduce herself, and she's going to talk a little bit more about the enrollment exemptions.
Thank you, Chris. This is Cheryl Wood, the MMIS Implementation Coordinator with the Health Systems Division, and I'm going to be talking about CCO enrollment exemptions. We're going to talk a little bit about enrollment and disenrollment as well. As Chris mentioned, we have different coverage types, and for each of our coverage types, we can offer different levels of exemption from those coverages. A medical exemption could mean that the client is not enrolled with a CCOA, but they might be enrolled with a CCOE or G. If they have a full exemption, they receive all of their services through the fee-for-service model. They can also have temporary exemptions for hospitalization or residential treatment. And again, those exemptions can come at any level. It could be CCO A, B, E, or G. Within the MMIS system, we can look at our MC special conditions or our managed care special conditions. They are part of the recipient information panel. And in the example in the slide here, we can see that we have a client who is exempt from CCOA because of a hospitalization from August through September of 2016. Historically, MMIS required exemptions to keep our carve-out populations from enrollment. And our carve-out populations are clients who have been carved out of different enrollment options. Medicare Dual, for example, needed an exemption to be not enrolled with medical coverage. A lot of those exemptions are no longer necessary. We're going to cover several options in the next few slides. But it's important to know that not all of the exemptions are necessary to be placed in the system to prevent the auto-assignment. If you need to prevent your clients from manual enrollment, you would still want an exemption. So on this slide, we talk about several different populations. Our carve-out populations not only include our Medicare Dual clients, they also include children who are in the child welfare system or in OIA, Oregon Youth Authority. They cover our HNA, Heritage Native American clients, and then any clients who have TPL. So on this chart, we start with our TPL clients. They are exempt from medical coverage, so they are going to have dental coverage only. The rest of our carve-outs will not auto-assign to medical. They could be enrolled in a CCOG. And then we have our HNA clients who will not auto-assign to any coverage at all. One of the caveats for our carve-out populations is that they can opt in and out of coverage at any time. So even though they don't auto-assign to medical, they can opt into medical if they choose. So again, talking about auto-assignment, this is where MMIS is going to auto-assign certain populations of clients. Any client with TPL is going to enroll with the dental plan. Our Medicare Dual clients will enroll with dental and mental health. Our Medicare clients who are enrolled with PACE will not auto-assign. Hospitalized clients will not auto-assign if they have the appropriate exemptions. Children in the child welfare system will auto-assign to dental and mental health. Our HNA, Heritage Native American clients will not auto-assign. And our Oregon Youth Authority clients will assign with dental and mental health. There are some exemptions for our child welfare and our OIA clients who have the perks listed at the bottom of the slide to allow them to have additional mental health coverage through OHP. And so this is just gives some more examples of our carve-out populations and how they can opt in and out of different coverage. We're talking about our TPL clients again, our Medicare Duals, our PACE, hospitalized clients, child welfare, HNA, and children who are in the OIA system. For most of our enrollment processing requests are handled through CES or our Client Enrollment Services team. Their email address is listed there in the first bullet. Routine requests are generally processed within 5 business days. Urgent requests are processed within 1 business day. It's important to flag your request with either urgent in the subject line or using the red exclamation point, high importance, so CES can work their urgent requests quickly. Historically, CES used to be able to process disenrollment requests and requests for exemptions for our carve-out populations. Unfortunately, this put them in a position of having to make medical decisions when they did not have that appropriate training. For any clients who are going to auto-assign into a certain level of coverage, for example, Medicare Dual clients may auto-assign into CCOG. Those disenrollment requests are now processed by Health Systems Division's Provider Clinical Support Team. They used to be known as the medical unit. The fax number is not included on the slide, but their fax number is 503-945-6548. And generally, the provider will submit a request to the Provider Clinical Support Team, including case notes and any diagnoses or situations why they're requesting for a client to be exempt from certain levels of coverage. It could include access to care or continuity of care, pregnancy exemptions, transplant services, or requests for out-of-state treatment. So we're going to talk a little bit about enrollment and disenrollment process and timing. Auto-assignment is the process where MMIS will assign clients to different levels of coverage. It could be CCO. We also have DCOs, which are dental care organizations, and we have one remaining MHO, which is a mental health organization. Depending on where the clients are located in the state, they may be auto-assigned into different levels of coverage. Enrollments are processed Monday through Wednesday, are effective on the following Monday. We're going to have some examples of this in a few more slides. And enrollments processed on a Thursday or Friday are effective the Monday after the following Monday. We call this our next weekly enrollment cycle. Auto assignments, our assignments are always effective on Mondays, but depending on the day of the week that they're processed, it will determine which Monday they're effective. Disenrollment changes in MMIS are typically effective at the end of the month. We do have some exceptions like a date of death or incarceration or a state hospital admit, where the disenrollment is effective on the date of the event. We can also request earlier than the end of month disenrollment for our carve-out populations if they're having urgent access to care needs. So our first examples for a newly eligible member, the member's eligibility with OHP begins on Friday, August 5th, and is going to follow the auto-enrollment cycle process. So the enrollment will be effective August 15th. It's the Monday after the following Monday from August 5th. And in the next example, we have another newly eligible member whose eligibility starts on Tuesday, August the 2nd, and is also following the auto-enrollment cycle process. And because Tuesday is in the beginning of the next weekly cycle, that client's enrollment will begin on August 8th. So in this example, we're having a client who is opting to change plans from one CCO to another, and the request comes in again on Monday, August 8th. And for this example, the client is going to disenroll at the end of the month, and then the enrollment with the new CCO will begin on the first of the following month. We can process urgent requests. So for this example, the client is requesting to change to another CCO on Monday, August the 8th. And we'll bring up all the bullets. So if the member is part of a carve-out one of the carve-out populations, we can disenroll earlier and enroll for next weekly. If the member has an urgent access to care issue, then that request can be sent to CES, and they'll triage and process that request. So I'm going to send it back over to Chris, and he's going to talk about CCO enrollment for residential treatment.
All right, thank you, Cheryl. So this rule has garnered a lot of questions. We know there's a lot of folks that work with APD that have asked about why this question or why this rule is in place and how it's supposed to work. So the rule is 410-141-3066, and that language that went into effect actually back September of 2015 talks about the definitions and requirements for when a member goes out of the area. The tricky part, of course, is why is the member going out of area. So on the next slide, this is a simple way to describe what is the member moving for. So you can see here, is this address change temporary? And for the most part, we are thinking that a residential facility is a temporary placement. That member is going to get to that facility or a special program and have the treatment with the goal of moving back home. And home is that home CCO. And that is really what 410-141-3066 is intended to do. In this case, we can't necessarily know why the address change is being made. You as a worker would, but if it is a temporary change, you can see on that left-hand side, yes, the new address would be a mailing change only, and the CCO of where they're from will continue to manage the care while they're out of area. If it's not, if it's a permanent change, if your client is moving from Deschutes County to Marion County, that would follow the normal process. You would update the address. The system will identify that as a permanent change and go out and go through the process that we just saw that Cheryl mentioned with the automatic enrollment and disenrollment cycle. The tricky part here is to know that if it's not a permanent move, if that member really is going to Marion County just to get services and then return home, critical to make sure that that change is only for the mailing address. I can't explain enough that this is where, and again, the concept behind home CCO is that the CCO that was working with that member before they went into a residential facility have established the care with them, has the continuity of what they medications they're on, the physicians they're seeing, the conditions that they have, and can work with that member while they're temporarily out of area, both to help them get services while they're there, and more importantly, to help them return and be successful when they return back to their home county. That is the goal of the home CCO rule. And so making sure that you're working with the CCO, working with that CCO's intensive case manager to understand when people are moving, why they're moving. The CCO has a vested interest in making sure that they're providing the care while that member's out of area and coordinating the care for routine visits, as well as making sure that they're plugged into whatever that facility is doing for the member, and then making sure that that transition happens successfully when they return home. We're not there yet. We know that this coordination doesn't happen as seamlessly as I've just described it in all areas. I think one of the things that we need to do is continue to work with our CCOs to make sure that they're reaching out, that they, one, know when those things are happening, know when their members are being treated out of area, and two, working with providers in those other counties to make sure that members are getting the care they need. So again, we've been working on this for a year, a little more than a year now. We will continue to work on it. We definitely need your help on the APD side because I think that's where a lot of that communication happens. And so if your CCO is working great, if you have that relationship with your intensive case managers, great. If not, I encourage you to reach out and establish those relationships because that's really the place where we find when those happen, the care gets seamlessly transitioned back and forth, the contracts happen, and the member gets taken care of. So I talked a little bit on the next slide about some of the challenges. One is, as I mentioned before, the permanent address gets changed in a temporary facility. What will happen is the system will see that, and as it's designed to do, will change that member's CCO enrollment. So now that member has switched plans. The new CCO may or may not have any idea of what that member's needs are, and particularly if they're there temporarily, we'll spend a lot of time and resources to understand that member's needs and care only for them to transfer back home. We also, as I mentioned, know that the service area and provider networks do not include all the residential facilities. So that means that there may be some CCO service areas that don't have access to those, but we also know that in a lot of cases the member is not able to stay in their home county because that facility doesn't exist. And as I mentioned too, definitely more coordination is needed. I think this is a work in progress. We've seen great strides, but we also have seen cases where we need to strive further. So our last slide here is really just the resources and contacts that we have. The first website that I'll put up there is the information about coordinated care, how you can learn about what we're doing in Oregon, how community advisory councils work, how the CMF waiver impacts that, what the Oregon's model is around coordinated care and why that's important. I highly recommend if you haven't had a chance to check that out, please do so. There's all kinds of links to individual CCO websites, information and videos about how coordinated care is working in Oregon, links to the metrics and some of the other pieces that CCOs are held accountable to do. The next link up there is around the administrative rulebook. I mentioned 410, 141, 3066. That and all the other rules that relate to managed care can be found at that second link. The DMAP Worker Guide, again, back from the days before we were health systems, we're working on updating that, but that's also a great resource to find information about some of these enrollment processes that Cheryl talked about. And then last and most important is the contact for client enrollment services, the ces.dmap@state.or.us. We're also working to update that to reflect our new health systems. But I think if there's additional questions that you have after today, please go ahead and send that email to CES with a subject line indicating webinar follow-up, and we'll make sure that those questions get answered. We know that there's a lot of questions around enrollment, how that impacts members, particularly how that impacts members that are in different areas of the state. Again, please reach out if you have specific questions to CES, and thank you for your participation today.